Top Med Talk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on Top Med Talk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Welcome to Top Med Talk. We are here in Chicago at the Society of Cardiovascular Anesthesiology 41st Annual Meeting. I'm Desiree, Chappell, host and managing editor of Top Med Talk, and I'm joined today by Saul Aronson.
Hi,
Saul,
Desiree.
how are you?
I'm good, thank you. How are you?
Good. I'm very good. You're not a special guest anymore.
Those days have passed.
That's right. You're just part of us now.
That's right.
Saul.
That's right.
So it's interesting. We're here at SCA, and the cool thing about you being here too is that you've been able to shake some hands and kiss some babies because you've been a past president.
It's been a long journey.
So, Saul, would you introduce our next guest here?
Jamie Ramsey, who is the Director of Cardiac Anesthesia at UCSF.
I'm the medical director of the ICU, the cardiac ICU at UCSF.
My apologies.
No problem.
And you've been there now for how long?
Almost 7 years.
Goodness gracious. And before that, Emory was your home.
Emory for 23 years.
And we are sitting also with somebody who Jamie used to work with in a previous life, Dr. Gerald Levy, who is now at Duke, but crossed paths a generation ago with Jamie at Emory. So we have a circle of life here.
That's fantastic. Well, gentlemen, thank you so much for sitting down with us. I know it's on the cuff here, or off the cuff. So tell us a little bit about the meeting so far and experiences kind of over the last couple days and what you're hoping to get out of the meeting over the next couple days.
Well, I'll tell you that my position is really a kind of an old guy position. I was very involved in the SCA as a junior faculty and in my career, and I worked my way through program committee and the board and president. And the people who founded the society, there were 3 founding fathers, and they became enduring board members. But this was in about 1979 or something like that. I can't remember the
I
first
think that's
meeting.
about correct,
yeah. And as you might imagine, 30 years later, they all kind of have dropped that responsibility in one way or the other. And a few years ago, Linda Shore, the president, Linda Shore Lesterson, thought that the board could benefit from some old guys with the history of the society and the experience of all the things we've gone through. And so she invited Glenn Gravely, another past president who was just before me, and me to become what are called founding father successors or something like that.
Oh, awesome.
So Glenn and I both joined a couple of years ago, joined the board again.
Oh, okay.
And so we're like, one of the analogies I like to give is like the 2 little Muppet men that sit up in the balcony and harass
the Muppets. That's hilarious.
so that we can just observe and we can give commentary to the board as we discuss issues that we might have had experience with in the past.
Yeah. Well, keep that foundational element of and keeping some of the themes, I'm sure, that have been running through the SCA and keep those relevant.
And I think one of the most wonderful things for me when I come to this meeting, in fact, definitely the most wonderful thing, is having been teaching at first McGill and then at Emory and now at UCSF. There's generations of residents and fellows, and it's hard for me to attend anything at this meeting because I'm always running into somebody who hasn't seen me for a while.
Yeah,
and
that's cool.
And then yesterday, one of the last fellows that I had at Emory before I left, Mike Mazeffi, has become very successful. He's at University of Maryland, and he's all over the program. And I watched him, listen to him yesterday on 2 different occasions. So that's a great satisfaction for me.
Yeah, a proud moment,
Yeah.
I'm sure.
Yeah.
So that's what you're probably looking forward to, is just catching up with everyone.
It really is great. I mean, the meeting is still wonderful. The meeting is almost 1,000 attendees, I think, like physician attendees. All the current topics in cardiovascular medicine as they relate to us are being discussed. There's surgeons here as well as anesthesiologists.
Yeah, I saw that.
So it's very gratifying to see the society
Jamie,
so successful.
given our sort of longevity, you mentioned current topics in cardiovascular anesthesiology. What are they today? In 2019, what would you bullet as the current topics in cardiology?
Well, there's a lot of them. Now, because I'm very ICU-centric, I would say that the first things that come to my mind are devices and ECMO. And both of those are well represented on the program. So left ventricular assist devices, when all three of us were in our practicing, very active young practicing years, there were no LVADs, right? There were no ventricular
There was a
assist
paucity
devices.
of LVADs, I think.
Yeah, they were being developed.
And they were primitive
Right.
Thoratec systems.
Yeah, and now they're very advanced. Every major center has an LVAD program that goes along with a heart failure program. ECMO. When I left ECMO, ECMO was just kind of something that a lot of big centers had. Centers with lung transplant was something that was really developing in the adult population. And now you can't really have an advanced cardiac program and a transplant program without ECMO.
It's ubiquitous, and it's such a quick go-to therapy for decompensating patients.
Right,
with
and if somebody couldn't come out of the operating room, couldn't come off the heart-lung machine, they were gone. That was it.
Yeah.
And now we bring them out, and many of these people, 40, 50% of these people who were clearly going to die are brought through, and usually it's a complicated, long process. But so those are two things that come to mind. Jerry can talk about coagulation.
Yeah, well, I was just going to say that along with the mechanical assist device, surge, if you will, as a commonplace, if you will, therapy for what we're now seeing as advanced heart failure, come with the collateral issues, not the least of which is the insipid coagulopathies and the management thereof. You had a session yesterday, Jerry. I was in the back row just listening. Very lively. You want to share some of the highlights of that session with us?
Absolutely, Saul. Thank you. So there was a session on coagulation and coagulation issues. 5 of us presented some of the perspective. My focus, among many in the coagulopathy arena and the cardiac surgical perioperative perspective, is also the new anticoagulants and management. But it was a great discussion and then a case review and with panel discussion as well as people from the audience. It's a big part of when you take blood extracorporeal, not only ECMO, but also with the ventricular assist device, you now have a non-vascular endothelial surface where everything's activated. There's sick patients. And it has a whole new paradigm and evolution. And that's sort of, interestingly, been my focus. And also work with a lot of hematologists on the planet on this, looking at coagulopathy and trying to come up with purified recombinant other strategies. So I think it's really interesting. I just want to say one important perspective is the evolution of the SCA. Dr. Saul Aronson and one of his colleagues started the echocardiography course some years back that has morphed into an incredible, important, intrinsic part of the SCA. And I think, Saul, your thoughtful vision and idea of doing that in years ago has really had major important effects in terms of the role of echo. And I think it would be really helpful for the group that you sort of describe it, if that's okay, because it really is.
This is such a pass the baton love fest.
It is. I love this.
No, but part of it is, what's so interesting is that the young crew doesn't know of Saul Aronson's original role as one of the leading trans-esophageal echocardiographers with Bob Savage. And Bob was my resident at Emory years ago. He was also a cardiologist. And together they really created this amazing course that I think has educated many people. I think it's really important to
well, thank
highlight
you.
this.
Kind of you to say that. It's all about pushing and passing and lateraling it forward, and that's why we are here today. That is the joy that we get. Sometimes in a soft, stealthy sort of way. But thank you for saying that. It's always nice to be remembered. Yeah. But it's all about, pushing it forward. And
I think one of the things that Saul did so well was help lead the society into a partnership with cardiologists. And the certification of anesthesiologists with the National Board of Echo was really a partnership. And the American Society of Echo, which was all cardiologists in the past, is now well represented, and the current president is an anesthesiologist from Duke, I might add.
Duke, yes.
This is a very Duke-centric interview.
Yeah. Well, but it's, I have the privilege of working with Dr. Aronson at Duke as well. But an interesting evolution. But I think your original contribution of setting up the course is important. And it is. Because what's interesting is that the Society of Cardiovascular Anesthesiology has morphed for years into an echo-centric meeting, although it's moving back in the coagulation, heart failure.
More the
I would tell you two of the big topics discussed by the board on Friday were related to echo. One of them is the certification of intraoperative or perioperative echo services, being kind of like a joint commission for echo labs, which nobody likes the idea much, and it's kind of controversial. And there's actually now a proposal that SCA members are going to get an email about inviting comments on the certification of perioperative echo labs and how they're run and managed and who runs them and who can be qualified for it. And another big topic is what's called structural heart, which is what cardiologists do with devices in the cath lab. Not with open surgery, and echo for that. Echo training for anesthesiologists currently and historically has never really involved this part of practice because it's really very new. It's only really evolved in the last, 10 or 20 years, structural heart?
15 years.
Yeah, and so now we are back kind of where Saul was in having to partner again with cardiologists and maintain our role. As anesthesiologists in this new space, because the cardiologists are very clearly in that space.
I think just to sort of sum up and reflect on 3 or 4 decades of the journey with respect to cardiovascular anesthesiologists. It's interesting how we've come around. I would characterize, and I would be interested and invite you guys to comment on this, that the specialty of cardiovascular anesthesiology has continuously evolved. Obviously, the anatomic and physiologic nuance and sophistication that we have learned and continue to grow to learn more with echo is important. I think the whole field of coagulation, management therapy, and pharmacology has evolved crazy in the last decade or two, and it I think constitutes a very significant, if you will, niche within our specialty. Mechanical assist device and intensive care management of the mechanical assist device probably, in my mind, underscore those 3 things. And then probably the fourth is just the continuum of care and the integration of care across, if you will, cardiovascular as a center of focus has really been what I would characterize today as the highlights of cardiovascular anesthesia.
I think a key word is collaboration. Yeah. And there was a nice ICU session about that as well, talking about involvement of cardiovascular anesthesiologists with ICU training, and even sometimes without, or with ICU training and not cardiovascular anesthesia training, working in cardiovascular ICUs.
Before we close, going forward, Horizon, what's next? And let me throw something out there just to sort of tease the pod, if you will. I think very interesting to me that the Enhanced Recovery Society of Cardiac Surgery with collaborative work with anesthesiologists and cardiology. Interesting next new wave. I think the policy of medicine and its influence on cardiac care and cardiac surgical care, I think, is going to drive change in the next decade. What are your thoughts on that, Jamie?
I think you're absolutely right. I think the collaborative conferences with surgeons and cardiologists, perioperative care providers of all kinds, have really created the concept of a heart team. And it used to be a little more balkanized. And we all understand now that when a patient presents with a pathology, there's several ways of approaching it. And each member of the heart team has a valid input in making care decisions about the patients. And it used to be if you had X decision, if you had X condition, you went straight on to Y solution. And now the cardiologists and the surgeons and the anesthesiologists all talk about the implications for peri-op care, the long-term implications, and some patients might be better with a less invasive approach, and some might be better with the old standard open approach.
Jerry, what can we do pre-surgery to better predict disposition strategy and effectiveness and efficiency of care in this value-based, resource-constrained environment?
It's a great question, Saul. I think, a lot of your work focusing on the preoperative clinics, especially in the anemia, is really important to optimize patients. The problem is that elective surgery is somewhat of an oxymoron, as patients, unfortunately, when they're sort of diagnosed, they usually often need a relatively urgent, they need to undergo heart surgery in a reasonable short time frame. But I think we need to better optimize patients. The coagulation story of stopping the anticoagulants, there's at least from the International Society of Thrombosis and Hemostasis, there's new publications on novel bridging strategies. In other words, don't bridge warfarin, just stop it and go through surgery. A lot of these need to be incorporated. And apologies for this, Saul, but Saul and the group at Duke has done a lot of really innovative work in your pre-op optimization.
I wasn't inviting that.
No, but and it wasn't. But this is really true, because focusing on the pre-operative, this has been a weak link in the chain. The pre-op optimization, the diabetic, the nutritional status. This is really an important perspective, and that being able to catch, recognize, and manage those patients is important. And it extends not only obviously in the hemostasis, but
well, I think this is a great example of Saul being on the horizon again, or looking around. No, I'm kidding, Saul. But it's true. I mean, I think those are definitely some of the things that we should look forward to.
I look forward, and thank you, by the way, Jerry. In addition to this sort of what I would call obvious things that we should be looking for and proactively pertubating in order to get somebody more ready for the stress, the trauma, anticipated known trauma of surgery. It's very interesting in that the tools, the technologies, the monitoring that we use to understand how a patient can tolerate the stress, albeit cardiopulmonary exercise testing, to understand what their regional, if you will, changes in perfusion might be, their blood pressure changes. All those things are not known until we're in the soup. And I think it's a very interesting new world to look forward to seeing if there's something more elegant that we can do with our predictive.
I think the Jerry started this topic with the right observation, and that is that you, like in the soup, is a great description of where we are when the patient comes to us. And we really have very little time in most cases, because these people come to us because they are in need of help. Sometimes medical therapy can put things off a little bit, but it's how do you prepare somebody for a relatively urgent procedure with very little time.
And remember, in the soup, it's multiple ingredients.
We're going to definitely beat that analogy, right?
On that note.
On that cheery note.
Yeah. On that cheery note.
I'm going to go back to the meeting.
1 second. Thank you guys so much for sitting down with us. We really appreciate it. Looking forward to the meeting, and thank you for everything that you've done for
Thank you.
SCA.
Thank you very much.
Cheers.
Top Med Talk.
It's Desiree Chappell here. Just a quick reminder, subscribe to Top Med Talk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at topmedtalk.com. That's www.topmedtalk.com.